Hi, everybody. Today I'm recording my lecture on the subject the patient and the special population. We will dedicate time to review the special population groups, some psychology of the patient, and how it is interfering with the surgical technologist performance and duties to the patient. As well, a few slides will be dedicated to the vital signs of the patients. Let's start. What are the patient needs? So we will define the patient-centered and the outcomes-oriented care, list and discuss human needs as described in the Maslow hierarchy. I hope it sounds a bell. Describe human basic psychological needs, and discuss common psychological needs of the surgical patient and the family. Every patient is unique, and the positive surgical outcome depends on the patient centered care. The surgical team bases its assessment and planning and interventions on the patient as an individual. When performing an evaluation of the patient, the surgical team must obtain data from a number of sources to make a thorough evaluation, discuss methods to determine the unique needs of the patients. The Maslow hierarchy of needs helps immensely in introduction of the idea of personal care. So Abraham Maslow was a psychologist from the beginning of the last century. The most basic needs are physiological, or because life sustain will be depending on maintenance of homeostasis that related to the physiological values. That is, that involves the biochemical, mechanical, and physical processes of the life. The triangle depicts a hierarchy in which the critical needs to preserve life are at the base level, but nonetheless it is an important part to preserve the life as a biochemical processes in a human being, and the other needs that create emotional, social, and spiritual fulfillment flow upwards. I highly advise you to practice your understanding that definitely you received in your previous academic classes, um, applying the scenario of the OR for a patient already in OR. What are the physiological needs of this person? And slowly, surely, you coming to the self-actualization. What will be self-actualization for this particular individual in this particular very special day of his or her surgery? Most basic needs must be met before fulfilling other needs. And this is why you see this triangle symbolized by triangular hierarchy, the physiological followed by security and safety, love, self-esteem, self-actualization. Maslow model provides an excellent guide for patient care and method of prioritizing the patient needs. Here we see the examples of the physiological domains that definitely during the OR permanence of the patient will be monitored based on the type of the procedure, type of anesthesia that you definitely familiar with. The psychological needs are safety and security, also feeling of the anxiety related to the possible changes, the anesthesia. Patients commonly fearing the surgical treatment, but underestimate the anesthesia, actually, anesthesia event and the possible effect on the body. So definitely, it's required explanation by doctors and or assure the understanding what will be expected and answering all questions related to this. In the social domain in love, belonging, acceptance, self-esteem, self-image, actualization, I invite you to actually a little bit reflect on this, how it can be related to the surgical patient and the exactly time of permanence of this individual in your care, what you can do, how you can help to this person in this particular moment. Because remember that our psychological psychological status depends and it works vice versa with a physiological, because if we are scared, if we are concerned, it will alter our stress response in the body. So medications will be working differently instead in a state of calmness of the patient. So it is really serious subject, and this is why you, as a surgical team member, have to fully understand your importance in this particular event as well. Patients react to illness and therapeutic intervention depends on the previous experience with illness, cultural factors, definitely age, knowledge of their condition, and uh, resilience to the stress. So altogether, we'll be producing the reaction and behavior of this particular patient. An important role for the healthcare provider is assisting patient to cope with their illness. And this is why for our ethics, the compassion of the healthcare provider is one of the main requirements in a personality. You probably remember in types of communications that we have our therapeutic communication, that actually the purpose of this method will be related to the caregiver that responds to explicit or implicit needs of the patient of the patient, and sometimes even without the asking directly verbally or healthcare provider for help, the properly trained medical team member can recognize that patient in distress and a psychological distress and required immediate attention. Um, as example, it is listening to a patient intently and staying on point and focusing when speaking to the patient, asking the open questions, not close questions as required answers yes or no. So you're trying to create this dialogue. Active listening, providing information, focusing, paraphrasing, and or restatement. So when the person asking the question, you paraphrase this question, trying to get more information from a patient, reflections, and definitely response. So definitely, living in a multicultural society, the professional in any field, but in healthcare, It may be even required more because we are in contact with individual in distress, in a concern. So that definitely you have to have a very distinct understanding the difference between a cultural competence and the cultural awareness. So I highly advise you to reflect on this, and if any question on this, I definitely will explore this in my answers in my lecture as well. The spiritual needs of the patients fluctuating based on the culture, based on their own personal opinions, and definitely required recognition as well. Patients often express their religious faith in the healthcare setting through the prayer or other rituals. Rituals depends life changing event, and it is important to physical and mental healing. Um, Please try to come out with some examples, maybe from your personal observation or during your experience in a clinical setting. The special patient populations. So special patient populations um, portion dedicated to the uh, patient with special needs. And here we're fluctuating from a geriatric to pediatric patient with the excessive body weight, or patients that suffering from neurological disorders, psychiatric disorders, but don't also underestimate your awareness in which changing your actually response to the patient, for example, in the custody of the law enforcement. So, in a pediatric patient, we start with the infant that from a day of birth to the hour our 20 day from this. After that, it's a newborn. I'm sorry, newborn, and from 1 month to the 18 months, we referring as an infant. So in this setting, I would like to remind you that pediatry as a medical science, actually branch of medical science, relatively young because not far like 200 years ago, the kids was actually considered as miniature adults and treated as adults. So definitely, you can imagine which outcome we had well, treating the kids as adults, because first of all, the body still in a development, not certain part of the body actually is not working on a full range. So all of this, the metabolic processes are also a little bit slightly different from um, adult patient, and during the disease or anyway pathological condition, the reaction of the pediatric patient can be different. So because of that, we're talking about human being, our psychology of the pediatric patient also different because the ability to fully understand and fine-tune attention of the patient on a particular situation will fluctuate based on age. Age is very approximately and very subjective. Um, to basically all patients. On this slide, please take your time to study how actually vital signs of the pediatric patient fluctuating based on the age. Again, it is a a general presentation, but you can see, like for example, heart rate and blood pressure will be systolic blood pressure changing from newborn before 1 month of life to, for example, or our preschool. You see how blood pressure actually relatively low compared to 80 and 110 or over 110 in preschool, but the heart rate is definitely in a preschooler will be much slower than in a newborn. As you will be communicating, and probably you did for during your clinical experience, and for some of you also personal as a parent, you know that infants they fear separation from caregiver, and this is why um, we need actually more time to set for in a pre-surgical preparation. The toddler can express also aggression and regression, and in our daily questions, I have some questions that I will ask you to work on your opinion and how you can react with in response to uh, some aggressive behavior of the toddler. So you have to be prepared definitely for this too, particularly if you are working in a pediatric specialty, but it is not limited. Preschooler, the punishment and abandonment because what I did something bad for to actually deserve this treatment because the understanding that has nothing to do with what you did, mainly if it's not a trauma or something that we can kind of relate. Relate this punishment, but still it should be explained to the preschooler, and you see how actually learning capacity of the individual changing. So the punishment means that there is a cause and event really or that or preschooler will start building up. And in the school age children, when they actually more already socialized, so what actually they usually do, they want to help. So it is definitely can be part of your communication with this particular kids. So in the adolescence, pride is in a body image. So adolescent that this person already start getting closer to the adults and their mentality. They are adults, right? But nonetheless, we have to still keep in mind, maybe not in a direct communication, where with them we can treat them as kids, and the your verbal expression should be as close as possible to their development and explanation, but taking consideration that yes, they are still kids. They still feel separation from their friends, their family, and definitely this can influence the outcomes as well. So in the geriatric patient, we usually referring the expression as a ADL or activities of daily living. So the as a dressing, as performing personal care, toileting, and so on. So sometimes the condition of this patients um, can aggravate this tasks in performance. So it's better that it can be reported by family member or by the same patient, that it can be assessed and helped. The perioperative assessment will gauge the older patient's ability to maintain daily activities and whether they will require post-care. So, no, definitely the older patients, but please don't take it just only older patients, because the risk related to coexisting disease, unfortunately, disease and pathological conditions are not present only in the elderly, but in a different category of patients. So we have to always see the chart and paying attention as an allergy, as well, kidney disease, liver diseases, whatever this individual can have. Normal physiological alteration, the change in the cardiovascular functions, the skin problems. So particularly for positioning, for movement of the patient. So the joint and problems, muscular, neuromuscular problems as well related to the certain neuropathy that can actually be aggravated if you don't pay attention. So it's kind of like immediately your positioning task as a surgical task. The sensorial deficiency that fluctuating from hearing to the sight as well. So definitely should be properly addressed, and this person should be helped. So the malnourishment patient. So we have even different. It is not sensorial, but it's still staying as a specialty. So in the usually in the patient care, we're dedicating a lot of time to the bariatric patients, right? We have even bariatric specialty as surgical procedures, but please pay attention that malnourished patient and causes of malnourishment can be very different. It can be malignancy, or we call this cachexia. It can be related to the presence of the infectious disease, as for example, AIDS or in advance in advanced stages. The certain psychosis that can lead to the actually bulimia, or for example anorexia. So this particular situations, you have to be very careful with the with this patients, with the movement of this patients, and definitely anticipate that this patient can actually have trauma related to the improper handling and improper positioning due to malnourishment, because the exposure of the vascular exposure of the nervous tissue is much more than in a patient that has a protection of the fat tissue. It's very common that my students ask me convergence between kilogram and the pounds. So to facilitate a little bit your tasks in at least or calculation of the weight for in case you need this in a imperial English formula or in a metric. So please take a time to practice on this. Bariatric patients, feeding patients with excessive body mass in that defined by weight in kilograms divided by height in metric, airway obstructions and hemodynamic function with definitely venous stasis that blood is not freely flowing to the heart. The heart is overwhelmed because has to pump all this blood for entire body and much bigger surface, respiratory problem. They are all present in the patient. So add to this most likely the diabetes. The special consideration must be taken for moving and handling of this category of the patients, and definitely the can be also the team that co-involved in the positioning of the patients. The risk associated with the surgery and patient with diabetes are very complex. The risk of infection at the surgical site is increased because of the compromised vascular supply. Because of this, the healing process also can be delayed. In the trauma patients that, for example, as a gunshot or knife wounds, automobile crash, or industrial accident, so we referring also to the like golden hour that actually the um, help should be the treatment should be start as close as possible to the trauma that occurred. Because why is that? Because the contamination of the wound will process much faster on exposed tissue. In ER, for example, during the triage, nurse will be always asking when the trauma occurred. There is a very large spectrum of diseases that are regarded as developmental and learning disabilities. So uh, one must use special care when communicating with the population and understanding that there is no one size fits for all approach. Um, The examples of the developmental disabilities, cerebral palsy, cognitive, and so on, autistic spectrum disorders, they are all related to the and developed during the period of growth and considered that occurring before age of 20. Again, it's very generally speaking. For example, in autistic spectrum disorders, that patient is usually not born with it, that you can detect it immediately. But meanwhile, the baby growth and changing in the development, so the certain pattern in the behavior can be detected by specialist. The psychological traumas when subject, person, individual were exposed to the very traumatic situations and re-experiences the trauma emotionally through the sense when triggered by specific clues or environment. It can be noise, it can be smell, so it unfortunately it is very common in veterans as well, but it is not limited only veterans because when person living, for example, some criminal attack, uh, surviving this trauma, uh, it will impact the person also in a behavioral level, and definitely it is required proper attention. The end of life is a period within which death is expected, and We usually referring as to days, from days to the months. We will dedicate a little bit more time in a few minutes to this subject. The individuals are unique and process dying through the different aspects of personality, culture, life experiences, and particularly circumstances. The Kubler-Ross model that based on a denial, anger, bargaining, depression, and acceptance. Please remember that it is not exact follow. So it is not the denial will be following by anger and bargaining. It is not like that. And sometimes the person actually or in this experiencing this actually event will jump from one to another, and this is when we're talking about that it is a personal experience and a personal approach to the subject will influence. So in the denial, we're referring to the defense mechanisms that forestall the full impact of the fact of death until the mind is ready to accept it. So usually it happens, the denial, the first when a person receiving the news of accidental death as well. In the anger, we feeling that this actually can be expressed in attempt to gain control over one's environment. Why it happened to me? So, for example, so the person start becoming very angry, because of this particular circumstances, and also that can be response to the need to change lifestyle, for example, or it can be related also to the financial changes, economical changes in the life of this person. The bargain may be seen as a way to postpone death. For example, please, can I wait till my kid will get married, or then they finish school, whatever it is, to kind of trick yourself mind. And also the depression, we referring also complete detachment with any reality in this person, with the immediate present. The acceptance, the stage when a patient and the family have come to the realization that death is inevitable and the psychological struggle no longer exists. So it can require sometimes months, sometimes years, then sometimes decades. Even it it is um, it is not directly related to the actually closeness of this death to the persons that passed away, but sometimes it is related just the personal understanding of the death, and related to the cultural events as well. The technologist should focus on what the patient is experiencing in the operating room or holding areas, and look for any change in the mood or anxiety level. The patient's verbal and physical clues should be the guideline rather than assumptions about what patient might feel the need are. The prompt communication with the nurses and the doctors. You don't have to give answers. You can refer this concern and to the physician, and physician will be taking care of this. But you are this uh, connection, this link between the patient and the physician as well. Listening to verbal clues and observing nonverbal clues, positioning of the patient, for example, on a gurney, combined with the respect for the individual, uh, can help the surgical technologist provide comfort to the patient in this important moment of their life. A health professional can guide family members toward coping strategies to help diffuse the tension and add order to the experience, for example, as support groups as well. In this matter, guys, also please link this subject to the legal aspect of your profession in the matter of the advanced directive documentation and consents that understanding and your strict application to this uh, steps are important in your proper professional performance. The surgical technologist should not provide medical information to the patient family or the friends, but may help facilitate communication between family and other professionals who provide support services. So when you receiving information or the questions from a family, you don't have to say, I don't know, I'm not trained in this. There is no reason. It's actual as almost like defensive response because nobody attacking you. They just asking questions. So the better way, I understand you. I understand the question. I understand your need. I will address it with a doctor. So with this, you giving the value of what actually the patient's family or patient ask you about, and definitely uh, plan of your actions. The right to die includes the right to refuse the treatment, while assisted suicide is often considered treatment with the intent to harm. So the living will details how healthcare to the dying patient should be delivered, as well as assign power of attorney to someone to act on this patient behalf. So please remember that when person actually receiving this decisional power as a power of attorney, this person has to also sign the legal document which confirming acceptance on of this responsibility, okay, or this decision making making power. Without this document, it can be none as our power of attorney. So the consensus of the patient or the family care provider make clinical decisions in the absence of the living will. The issue and the procedures following the death. So that we will see few aspects of this particular steps as well. So what is actually cultural competence? The cultural competence supports any care across the culture, actually, and you don't have to accept what this actually culture does, but you uh, or share this, but you respecting the of the people who following this particular thoughts and have this values. So they acquired through the experience and active learning definitely begins with the acceptance and respect. The exact protocol for postmortem care is carefully defined by every healthcare facility. Uh, all staff members who perform postmortem care must be completely familiar with this protocol, and there should be no ambiguity about this process. In your clinical setting, it will be also dedicated time to train you in this matter as well. It is fluctuating from a hospital and differentiate from hospital and, for example, surgical center because as you know, the surgical center is mainly ambulatory and the death is not expected in the setting. Nonetheless, there will be procedure to follow in the circumstances as well. Please familiarize yourself with the terms as livor mortis in rigor mortis. I think it should recall your AP subject as well. So livor mortis, if you don't remember immediately, it is a process of collection of the fluid under pressure from a body weight or gravity, depends on which position the actual body is, supine or prone position or can be. In rigor mortis, you probably can recall from a muscular tissue, and it will be will start on within like 15 minutes after the biological death and peaks in 8-10 hours. So rigor mortis begins in the head and progresses to the feet. Postmortem care prepares the body for viewing by the family and assists in the future handling procedure carried out by the morgue and mortuary. The documentation related to the death of the patient is completed by attending physician and anesthesiologist. Registration of the death is a separate legal document that is completed by attending physician as well. So for coroner cases, when circumstances that determines coroner involvement can be death in the war room or emergency, unwitnessed death, death after admission from another facility, when criminal activity is suspected, as well suicide, death of a prisoner, death secondary to an infectious disease or workplace death. Any specimens produced during the surgical procedure become the property of the coroner in the circumstances as well. They must be transferred directly from the OR as the specified by hospital protocol using universal precaution. Organ recovery. So, or gift of life. Um, we have certain situations, you know, that when patients actually in a waiting list for organs or from deceased individuals, It is not, you know that it is not easy process and a procedure because the matching of the tissue is crucial in the circumstances, and nonetheless, as close it can be, we still will have to place the recipient on for a life period of time on the immunosuppressant medications. So I highly advise you to definitely follow this link and see this videos, but to also review the article or you can find on the AST.org, our professional website that related to the organ donations. It actually will help you immensely in understanding, and because it can be also your field of practice as organ procurement. So the person can make the decision to donate tissue or whole organs. In many states, this permission may be verified on the individual driver license, like for example in California, or it happening as well in a situation, for example, between a heart beating cadaver and non-heart beating cadaver. So how what is the difference? So the heart beating cadaver is a body in which tissue perfusion can be maintained during and immediately after death to preserve the perfusion of the organs, as a kidney, as a lungs, as a heart. So the tissue from non-heart beating cadaver are restricted to those that do not need perfusion. The tissue that the tissues do not need perfusion, as for example, bones, the skin can be related, the cornea as well. So please be familiar because this actually not uncommon question. What are the ways a healthcare worker might respond to the patient death and some activities that might help us to cope with this tragic events, because we are healthcare provider. We want to provide and provide the practice to reestablish the health, right? But unfortunately, it can happen that person can pass away. And reactions may include shock and denial, depression, or several psychological responses. Debriefing period, spontaneous support by co-workers, organized actually support group and distraction, the self-care and strategies used to cope, and as well psychological team, actually professionals, psychologists are available in the situation as well. So please don't play hardball. We are humans, and we need sometimes help of a professional to address our needs. I hope that this actually review was helpful. I highly advise you do not limit your review to the PowerPoint, but also go and refresh your understanding with your textbook and definitely AST guidelines and practice. Thank you very much for your attention. Any questions you can address to the video or under the video, I mean, or during our sessions. Thank you.